Hi everyone, so this is the first video lecture for Chapter 1. I will do these key point video lectures for the majority of the chapters that we will cover throughout the course. Some of them will have a little bit more information than others, and this is not meant to be a fully involved lecture. So you still will be responsible for reading the material out of the textbook and then also covering the material that is provided to you in the lecture handout slides. All right, so let's get started. So we'll start with lesson 1.1, and the first question that we want to answer is, how do pathological conditions affect the body's homeostasis? So this is the thing. Homeostasis is the internal stability of the body, and that means that it is the balance between good and evil, if you will. So your body is all the time trying to achieve this perfect balance or this homeostasis. So pathological conditions cause abnormal conditions that are measurably changed. So if you have a bacteria or a virus or something that comes into the body, there should be some type of negative effect or change that is measurable. And that changes or causes fluctuation in the balance between the good and evil in the body, and thereby reduces the body's ability to achieve that homeostatic level. So what are some differences between signs and symptoms? So signs and symptoms, symptoms are negative characteristics or a departure from normal status. So here's the thing with symptoms. Some people have these things called idiosyncrasies, and that means that they handle things in their own manner. For example, I tolerate pain pretty well. One of my children does not at all, like at all. If she gets a bruise, she freaks out. If something pokes her, she freaks out. She's terrified of needles, whereas they don't bother me. So even though that level of pain that's associated, say, for example, with a blood draw doesn't bother me at all, she freaks out. So for me, if all of a sudden the pain associated with the blood draw that normally isn't bothersome to me becomes excruciatingly painful, then that could be a symptom of something that is not right within my body. So signs are abnormal objective findings, and signs of disease are often going to correlate with those symptoms. So sometimes, though, it's important to remember that the signs of the disease, although they typically correlate with those symptoms, they may be noted in an asymptomatic patient, as is in the discovery of a painless tumor or the finding of an abnormal blood pressure reading in a person that has undiagnosed essential hypertension. So sometimes there are signs but no symptoms, and that's important to remember also. The difference between acute and chronic diseases. Acute illnesses have an abrupt onset, so it's a very quick onset of symptoms, and it runs a brief course typically. And usually, by acute and brief course, they mean no more than 6 months. So 6 months seems like a long time to be sick, but when you are looking at the longevity of chronic diseases, 6 months is actually a very small amount of time. For chronic illnesses, these diseases will develop slowly. They can be intermittent, so they can show up and you can have symptoms and signs, and then they can kind of recess and you have nothing, and then they can come back again. And they will last longer than 6 months. So persons who have continuous pain as part of chronic syndromes will often also experience depression, so that's something to be aware of as well. So depression can be a symptom of a chronic illness that has yet been diagnosed, so just kind of keep that in mind. So let's look at number 3, and those are where we want to identify the predisposing factors of disease. Those predisposing factors are age, gender, lifestyle, environment, heredity, and immunodeficiency. So what I would like for you to remember is that although the recognition of these risk factors may be significant in prevention, diagnosis, and prognosis, it does not precisely predict the occurrence of disease, nor does the absence of predisposing factors necessarily protect against the development of a disease. So just there are people sometimes who live very healthily. I had a guest speaker come into one of my previous classes, and he was a heart transplant recipient. The guy was a physician and lived very healthy. He exercised regularly. In fact, he collapsed on the side of a highway after he was out jogging, and had a heart attack. And so he was like the least likely candidate to have a massive cardiac event, and yet he did and ended up having a heart transplant. So basically what I'm trying to get across here is that even though they may have predisposing factors of a disease that would indicate that that would be the process or the path that they're going to follow, they may also not be in possession of those predisposing factors, and they may be the least likely person to end up with a disease and still end up with that condition or disease. So these are predisposing, which means that you're more likely to develop this, but doesn't necessarily mean you will. And you could not have any of these and still end up with a disease. So remember that. So I want to explain the body's natural defense system against infection. And what you need to know here is that injury and disease impose stress on the body's equilibrium and then disrupt or destroy cellular functions. So what happens is we have this thing called an inflammatory response, and that's your body's natural defense system against infection. You have an acute inflammation, which is, while it seems to be an abnormal response, inflammation is actually a normal protective physiologic response to tissue injury and disease. And it usually will be accompanied by redness, swelling, heat, pain, loss of function in the area that's swollen and affected. And that the whole point of this inflammatory response is to kill off whatever it is that is making the body sick in that area. So widespread inflammation is marked typically by systemic symptoms such as fever, malaise, which is general tiredness and just kind of run down, loss of appetite. We can do some blood tests that will reveal an elevated white blood cell count, which is an indicator for an infection that is present in the body somewhere. Or also there could be an elevated erythrocyte sedimentation rate, which is an ESR, and that is also an indicator for inflammation in certain areas of the body. So what are superbugs and super strains? Okay, so superbugs actually are making national headlines right now. A woman just a few weeks ago, I think at the beginning of May, and I think she was in North Carolina, I just read this article a couple of weeks ago, was diagnosed with a urinary tract infection, and within that urinary tract infection, they discovered a specific type of bacteria that is known as a superbug, and it is completely resistant to every antibiotic known to man, which is terrifying because that is the first case of this particular superbug that has been discovered in the United States. That means, you guys know how population works, so that means that if this lady has it, it's not going to be long before this superbug that is untreatable by antibiotics is going to start popping up in other places and other patients as well. So superbugs are virulent antibiotic-resistant strains of bacteria. And there are a couple of types that you need to know about. The first is MRSA, and that's methicillin-resistant strains of Staphylococcus aureus. And those are usually to blame for skin and tissue infections. They are the leading cause of surgical wound infections because they are typically found in hospitals. Also, they are found commonly in jails and other crowded living quarters, and then other community environments. So sometimes you'll see them in other places, but hospitals are typically where MRSA is found most often. If we encourage patients to have excellent hygiene practices, then that helps prevent the spread of MRSA. MRSA is nasty. Several years ago, probably 10 years ago now already, man, that seems like not very long ago, but there was an outbreak. I moved here from Indiana last year, and there was an outbreak across northeastern Indiana of MRSA. They shut down entire school systems I mean, multiple schools within the district to clean the schools for 2 weeks straight because MRSA had gotten out of hand. And that makes sense because it's a community environment. There's a lot of kids, and kids aren't the most hygienic creatures. So MRSA can be pretty nasty, and it can spread pretty quickly if it's left unchecked. The second type is VRE, and that is vancomycin-resistant enterococci. And it's an increasing problem in chronic care facilities and hospitals because there are only a few antibiotics that can be used to treat VRE. The last one is CRE, and that's also another cause for concern. It is carbapenem-resistant enterobacterococci, and those infections are difficult to treat because they have high levels of resistance, even to the antibiotics that we consider to be last resort. These CRE infections usually occur among patients that are receiving treatment for other infections. So just be mindful of those superbug varieties. Super strains kind of go hand in hand with those superbugs, whereas they are a particular strain of a virus or bacteria, typically bacteria that is immune to antibiotic treatments. So lastly here, number 6, some ways in which pathogens can cause disease. We already talked about a couple of them, acute illness and chronic illnesses, but there's also syndromes. And syndrome is defined as a collection of signs and symptoms that characterize a disorder or a condition. And then the next thing I want you to remember is the word pathogenesis, and those are the different stages of development of a disease. So pathogens are categorically defined as disease-causing agents, and so that's what their whole job is to cause disease. But pathogenesis is the various stages of development of that disease, and where a person is at in the development of a disease is going to determine how we what course of treatment we take for that disease and pertaining to the stage that they're in. So the pathogenesis of a disease varies with the individual patient, the causative factors, and the medical intervention as well. So lesson 1.2, we're going to talk about the differences first between benign and malignant neoplasms. So there are some major differences between the two. First of all, benign neoplasms will develop slowly. They can arise from any tissue, and they're typically going to resemble the tissue of origin. So if they arise from stomach tissue, the tumors will take on the shape of stomach tissues. If they arise from throat tissue, then they will take on the shape and structure of throat tissue cells. These tissues, benign tissues, also will rarely recur after they have been surgically removed. The thing with benign lesions is that even though they are benign, they do take up space, and so complications can result from compression of tissue by the lesion or obstruction of organs. So for malignant tumors, the cells are variable in appearance and they are disorderly, which means that they don't follow the suit of the tissue that they arise from. They behave erratically and multiply very quickly. They have the ability to invade other tissues. That's called metastasis. And then metastasis is what actually makes the neoplasm more difficult to eradicate. So sometimes because the cancer spreads or metastasizes, it's difficult to get all of the cancer out from all of the surrounding tissues that spread to. So malignant tumors can represent a serious threat to the health and life and well-being of a person. Those are cancerous tumors. They are very dangerous in most circumstances. Often malignant cells will enter the bloodstream or the lymphatic vessels, and that's going to lead to the metastasis or the tumor growth in other areas of the body. So if you're wondering how somebody can have throat cancer in their pelvis, that's how. Because the cancer will start in the throat and then spread through the bloodstream or lymphatic vessels down to areas in the pelvis, and then they will develop pelvic cancer on top of that metastasized from their throat cancer. So when we're looking at the relationship between mutations in the genetic code and cancer and other diseases, genetics are incredibly interesting, at least in my opinion. They're very, very interesting. There's a lot left to be discovered in how genetics factor into one's health outlook. But we know much about genetics so far. And what we do know is that if you have a strong family history of a particular type of disease, then there's likely to be a genetic mutation that is causing that disease to be passed down from generation to generation. So, for example, one of the most widely known examples of how genetics can play a role or factor into healthcare for generations is breast cancer. So for ladies, we are typically asked at our OBGYN appointments if we have a history of breast cancer in our family. And for example, my family has a very strong history of breast cancer. Both of my great-grandmothers died actually 5 days apart from breast cancer. Two of my aunts, both of my mom's sisters, have had breast cancer scares. My grandmother has had breast cancer twice in 6 years. So we have a very, very strong history of breast cancer. So that's something that I always share with my physicians. I like to keep them aware of, because that means that the odds of me turning up with breast cancer are pretty good. So in order to try to catch things early, I make sure that I have my annual exams done, I have my mammos done when I'm supposed to, because I would like to keep them attached to me instead of not attached to me. So the thing is that because I know, it's unfortunate that I've had this history of breast cancer in the women in my family, but because I know that I have had that, I can be proactive and attempt to get ahead of whatever this genetic mutation is. And actually, for breast cancer, here's a fun fact for you. There is a genetic test, it's called a BRCA test, that can actually single out the gene that is typically responsible for breast cancer. And you can have that test done. Insurance doesn't typically cover it, and it's about $5,000 the last time I checked 10 years ago to have that genetic testing done. But you can have this BRCA antigen or this BRCA gene ran and through your blood work and find out if you are likely to develop breast cancer. In fact, I think Angelina Jolie did that, and when it was found that her BRCA gene indicated that she would most likely develop breast cancer, she elected to go a double mastectomy without ever even having breast cancer to begin with. She just wanted to not deal with it at all, so she figured she would take her breasts off, and by having them removed, eliminated the need to worry about breast cancer in the future. So that's kind of how genetics work with cancer, and they also work that way with other diseases. There's things like autosomal dominant, autosomal recessive, X-linked, which are sex-linked recessive genes, and those are all ways that you can inherit these different types of mutant genes and the various gene locations that they possess. Things like Huntington disease, Marfan syndrome, cystic fibrosis, phenylketonuria, Duchenne muscular dystrophy, hemophilia, those are all different genetically inherited diseases. Okay, so the guidelines for cancer prevention, they are pretty widely publicized because obviously there's a movement, a fight, a continual fight to prevent cancer so that way we don't have to cure it. Some of the things that you can do are consume a diet rich in fruits, vegetables, and whole grains. Eliminate active and passive exposure to cigarette smoke. Eliminate skin exposure to sunlight. Wear your sunblock. That's especially important in California, I've learned since I moved here. It's always sunny here. You want to limit the use of alcohol, avoid excessive exposure to radiation and radon, avoid chemical agents known to be carcinogenic. I just want to take a break right there and talk about that for a minute. I have to tell you that moving from the Midwest to the West Coast was quite a bit of a shock. My background, my master's is in public health, and so public health is, kind of inherent to my nature. And so the first place that we excuse me, that we walked into to eat dinner the night that we arrived in California. So we got here, we drove in, and we arrived here at about 5 o'clock, and we were starving. And so we went over to that Fuddruckers place, I think it is, over in Fairfield by the Solano Mall. And so we were in there to get a burger, and the very first thing I noticed when we walked in there was a placard that was on their wall that listed off all of the things that are known to be carcinogenic in the state of California. So anything that your food could have come in contact with that could cause cancer or is known to the state of California to cause cancer was listed on this placard. And my husband was like, man, that's kind of scary. And I'm like, man, that's kind of awesome. Where in Indiana have you ever seen them list all the things that could possibly give you cancer in your food and the things that you're going to consume there? And so he thought it was kind of weird. I thought it was kind of awesome because California is very progressive, if nothing short of kind of annoying. It's very progressive in making sure that the public is aware of how they can protect their health. So those placards that you see everywhere are there for a reason, and they're there for you to utilize that information to help protect yourself and prevent occurrences of cancer. Okay, so that being said, more cancer prevention, you want to increase physical activity, maintain a healthy weight, which is much easier said than done, believe me. Protect against sexually transmitted infections, including making sure that you get the HPV vaccine. So just a fun fact for you here, statistics from the American Cancer Society estimate that nearly 1.6 million Americans are diagnosed with invasive cancer, and more than 500,000 of those, so more than 500,000 of those 1.6 million diagnosed every year, die. So that's an insane amount of people that are diagnosed with cancer and dying from cancer every year. 1 out of every 4 deaths in the United States is found to be cancer related also. So if you can take heed of some of those prevention guidelines and try to help yourself out a little bit or help your loved ones out in preventing the possibility of getting cancer, you will all be the better for it. Okay, so stages of cancer. There are, there's something called the TNM staging system. And the staging system stages the size and extent of the primary tumor. And so the stage reflects tumor size and the extent of the tumor that has spread and has important implications for the prognosis and in the determination of treatment choice. So what stage they are at is going to determine how we go about their treatment, excuse me, it tickled my throat, and how well they're expected to recover and beat their cancer. So staging is actually a terminology that institutions can use to communicate patient information so that the procedures and staging systems used for staging have to be standardized worldwide. So the staging system in the United States is the same as it is in Europe, is the same as it is in Australia, is the same as it is in Vietnam. And that's so that people can receive standardized treatment based on their stage. So stage 1 is best prognosis. Stage 4 is going to be the most advanced cancer. Once all of the parameters are defined for that tumor, they're going to be combined to assign a stage number of 1, 2, 3, or 4. So there's a table in your book, I think it's on page 14, that gives you stages of cancer. You definitely want to read through that because it's got some great information in there for you on cancer staging. There are some other factors that I want you to know about other than cancer stage that can affect prognosis, and those involve age, serum concentration, the time between diagnosis of cancer and treatment received also. So the sooner, obviously, the sooner the cancer is diagnosed and then we get treatment going, the better their chances are for a good prognosis. So again, check out that table, the cancer staging table on page 14, because you will be responsible for the information found in that table. So how does chemotherapy fight cancer? Chemotherapy It involves the use of medicines that are aimed to destroy the cancer cells. Most of the drugs affect cell replication, so that chemotherapy is going to be most effective against rapidly dividing cells, such as cancer cells. It's typically given in cycles that include a treatment period, and then we have to give the patient a recovery period because chemotherapy is horrible. Not only does it kill all of the good stuff, all of the bad stuff, it typically kills off a lot of the good cells as well. And that leaves the patient very vulnerable and very immunocompromised. And so it's important that after they go through a treatment cycle, then we give them a period of recovery. So they may do chemo for like twice a week, 12 weeks, and then we give them a 6-week recovery to try to build up their strength and their, replenish themselves again. So hospice care is for terminally ill persons, and they can be referred to hospice care for compassionate, holistic case management. Hospice care focuses on the comfort and support for the family while providing comfort and dignity and privacy to the patient. Hospice care is typically covered by health insurance if a patient has a terminal illness, but the physician usually has to certify that the patient likely has less than 6 months of life remaining in order for insurance to pick up hospice care. Hospice does not hasten or postpone death. It just kind of lets things progress naturally. But again, one of the conditions for hospice care is typically that they aren't expected to live longer than 6 months. Okay, so 3 classes of immune disorders that break down your body's immune system. The body's immune system. There are hypersensitivity reactions, which are allergic reactions, autoimmune diseases, and immunodeficiency disorders. So hypersensitivity is basically an allergic reaction or allergic disease, I guess, is a hypersensitivity of the body to a substance or an allergen that is ordinarily considered harmless. So it may be harmless to the general population, but to that person, they have an allergic reaction to that certain substance. This reaction triggers stimulation of immunoglobulin antibodies. Subsequent exposures are going to trigger the allergic response, which will cause the release of a substance called histamine. These responses can range from mild and self-limiting to severe and life-threatening. Common allergic conditions include seasonal allergic rhinitis, which is hay fever, also allergic sinusitis, bronchial asthma, urticaria, which is hives, and then eczema as well. So allergies are typically controlled with proper diagnosis and treatment, although I would like for you to know that severe systemic manifestations of allergic responses include anaphylaxis, which involves anaphylactic shock, serum sickness, arthralgia, and status asthmaticus as well. So those are the more severe things that you need to know about hypersensitivity and allergic response systems. So let's look at the responses to autoimmune disease. Normally, the immune system is able to distinguish self-antigens, which are typically harmless, from foreign antigens, which always present a threat to the body. And so with autoimmune diseases, the immune system has an inappropriate or excessive response, and that causes problems for the patient. So causative factors for autoimmune diseases can be primary. They can be manifested by a characteristic disease in the number of T cells and B cells, which leaves the body unable to adequately defend itself against infection and tumors. What triggers autoimmune responses is still kind of a mystery. Nobody really knows. But basically what happens with autoimmune responses is your body starts to attack its own tissue, thinking that it's not supposed to be there when in fact it is supposed to be there, and that causes a problem. Autoimmune diseases are typically a little bit more difficult to manage because the body's immune system is always attacking itself. So there are some essential steps in the diagnosis of a disease, some things that have to happen in order for us to be able to diagnose a disease that may or may not be present. So the first is we're going to obtain a medical history. When a person seeks medical attention and then they describe their symptoms or they exhibit signs of a disease, we're going to start off with obtaining their medical history. This interview is going to help establish a treatment plan for that patient. And it's more of an investigative process. So we want to investigate the various parts of this person's personal medical history, family history, all of those things that will help us investigate the cause of their disease and then make a diagnosis. The second is going to be the physical exam. That's just where we do a review of systems. So they'll do, the physician will do inspection, auscultation, percussion, and that's where they tap on your belly and they listen to your heart and your lungs with a stethoscope. And they may have you do some range of motion where they make you do your arms in circles, check your reflexes, where they hit your knees and elbows with that little hammer looking thing. So they can do all of those things, and all of that is in the physical exam. And then the last step will be diagnostic studies and lab tests. So they may find that they need to order some lab tests. So here's the way it works with diagnosis. Basically, the doctor has an idea. He looks at the whole big clinical picture, reviews the patient's history, looks at the clinical picture after the review of systems, and says, okay, based on A, B, and C, it seems to me that you probably have this disease. And so in order to find out if you actually have the disease that he suspects that you have, then you have to typically have clinical confirmation. And in order to do that, it's going to probably require lab tests or radiology tests. So they'll have some diagnostic studies ordered at the end of it, some lab tests ordered, and that's going to allow them to microscopically examine cells and tissues and also perform a chemical analysis on the blood to actually confirm clinically or deny clinically his suspected diagnosis. All right, so a holistic approach is going to focus on the needs of the whole person. And so that means that it considers the patient's social, emotional, intellectual, and spiritual components as well as their physical health. The physical and psychological well-being of the individual are going to be dependent on each other in a holistic approach. And so it's important that we individualize care for that patient. The personality of the patient and the patient's environment, lifestyle of the patient, all of those things are going to be factored into the care plan. And the practitioner then will acknowledge the uniqueness of the patient with regard to his or her needs. And so basically they're going to tailor a care plan specifically to that individual based on many, many factors, inclusive of those directly related to their physical health and their environment, their emotional state, all of those things. This holistic approach also is going to encourage the patient to consciously pursue the highest possible expressions of being. So it's a very spiritual type of medicine. One thing I want you to know is that although integrating all of the needs of a patient is compatible with the comprehensive treatment plans of traditional medicine, holistic medicine may also incorporate a variety of non-traditional methods of treatment, and those could be empirical or experimental. So just kind of keep that in mind. Even though it follows the traditional path of medicine, it involves typically more than that. So lastly here, cultural diversity in clinical practice. I cannot even begin to explain to you how important cultural diversity awareness is in clinical practice. In fact, several years ago, I co-authored a diversity in healthcare textbook with another lady, and it was such an enlightening experience. I've worked in healthcare for many, many, many years, and all of the time things change and people move all over the place, and you get an influx of one culture or another. And if you don't know how to deal with those people, you can make their life literally hell for them while they're already going through a scary time, while they're already going through things that they're unfamiliar with, a foreign process to them. And so it's important to understand that people and be respectful of people's diversity and their cultural influences on their own healthcare. Okay, so that being said, individuality with cultural diversity is Oh, sorry, let me find my notes. Based on numerous differences, there's differences in language, religious beliefs, views about health issues, and life experiences. All those things are going to factor in to how someone's culture is going to affect their medical care. The success of cultural diversity in clinical practice is going to be based on the willingness of providers to overcome barriers and to also acquire knowledge of different cultures. So let me give you this fact. According to the U.S. Census Bureau, the number of foreign-born U.S. residents increased from 19 million to about 40 million. 40 million U.S. citizens that are foreign-born in between 1990 and 2010. So that's double the number of foreign-born U.S. citizens. And those are just the ones that have went through the process to become citizens. So there are many, many more who haven't gotten through that process yet, who also will need health care at some point. Some hospitals will have a cultural pocket guide that they'll give you that notes such traditions that, is maybe birth traditions or death traditions, dietary rituals and preferences. But it's really up to you as a healthcare worker, as a provider, to make sure that if you live in an area with a large influx of, say, Burmese, then you are aware of the Burmese culture's expectations. So let me kind of give you an example, just because this is often overlooked in healthcare and it's incredibly important. My husband is Vietnamese. He was born in Vietnam, and I come from a very large Italian family. And so we don't really think twice about donating blood. We don't really think twice about having healthcare procedures done. It's not a big deal. So I had arranged at my previous campus for a bloodmobile to come, for the Red Cross to come when we were doing a blood donation drive. And so I go out there and I begged my husband to come on his lunch and to donate blood. And he absolutely refused to donate blood. And it's not because he's terrified of needles, because I've watched him get injections. He's not scared of needles at all. It is because in his culture, they believe that blood is there for a reason. It shouldn't be taken out. If you take out too much, then you've got an imbalance between, the good and evil in the body, and so that's a problem for him. So he won't do it. He will not donate blood. I, on the other hand, believe that your blood supply is replenished. Those blood cells that you donate will be replenished, and you'll get them back. And you can donate it again in 8 weeks. So we agree to disagree on the facts of whether or not that, the blood will stay gone or whether it will come back. But really, I had to learn to respect the fact that even though my culture dictates otherwise, his culture believes that it is inappropriate to donate blood and to put your blood in somebody else's body, or to take blood out of your body unnecessarily. So little things like that can make a big difference when you're looking at patient care. All right. So for lesson 1.3, let's look first at the physiology of pain, of treatment, and the treatment and referred pain. So pain can be either physiologic or psychologic. So it can be, you can have definitive feelings of pain, or it can be psychologic pain, where it's a little bit more on the mental side of things. So in regards to the physiology of pain, the physiology of pain involves the stimulation of specialized nerve endings that are called nociceptors. And so nociceptors are found on free sensory nerve endings in the superficial portions of the skin. Also, they can be found in some tissues of internal or visceral organs, as well as in joint capsules, in the periosteum of bones, and then surrounding the walls of blood vessels, and in very certain types of deep tissue. So these nociceptors will signal injury or tissue damage by causing pain. You feel pain, and that's how you know that you've incurred an injury or tissue damage. So the receptors are going to respond to temperature extremes, mechanical damage, dissolved chemicals. And basically what happens is a very strong stimulus may excite all three types. So it could create a burning type of sensation. Psychological or emotional pain is as real as pain with physical cause to the person experiencing it. That's the thing to remember. So when you're trying to figure out the difference between whether a person is experiencing physiological pain or psychological pain, you need to understand that psychological pain is just as real as the physical pain that they are in to that patient at that time. One more thing I would like for you to remember regarding the physiology of pain is that stress can alter both perception and response to the pain. And pain causes stress. So that's something to be aware of. The cerebral cortex is responsible for the interpretation of pain, and therefore it must be functioning at normal capacity in order for that interpretation to occur. So just be mindful of the fact that stress can alter actual pain ratings. So lastly, positive health behaviors. The goal of, I don't know how much patient teaching you guys are going to be doing in your settings, but the goal of patient teaching is to influence positive health behaviors. And so we want to encourage patients to be compliant with the medical treatment plan that the provider has laid out for them. We want to offer support, guidance, and clear instructions for the patient, and give them examples of positive health behaviors to follow. We want to develop trusting therapeutic relationships with those patients. And then lastly, we want to help them learn how to effectively deal with their condition by making healthy lifestyle choices. So better diet choices, better exercise choices, reducing environmental factors that it can be harmful to them. So let's look at some non-traditional medical therapies. These non-traditional medical therapies will typically involve things such as acupuncture, osteopathy, chiropractic medicine, massage and reflexology, aromatherapy, the use of herbs and oils. Essential oils are all the rage right now, diet and nutrition therapies, and then homeopathy as well. By definition, complementary medicine is used together with conventional medicine. So these non-traditional medical therapies are used complementary to conventional medical practices. So when we look at integrative medicine, what that basically means is that we are integrating all of these different non-traditional medical therapies in with those traditional therapies in order to provide the best possible care for that patient's condition. So for example, reflexology is a form of massage, and that's going to direct its efforts primarily towards massage of the feet and sometimes of the hands, because a lot of times the nerve endings, massaging of the nerve endings in the feet and the hands will provide relief for specific areas of pain on the body. Even though that's not something a MD would do, they may find that it's beneficial to have that done for the patient or to direct the patient to a reflexologist, because it may provide some relief that helps alleviate the use of some of the stronger opiate medications that are used to manage pain typically. So that's kind of how integrative medicine all kind of comes together. Okay, so that's it for chapter 1, and I will talk to you in chapter 2.